welcome back to the deep dive. I've got to be honest with you. Looking at the stack of papers for today's session, I felt a familiar kind of weight. You know that feeling when you pick up a book that you know is going to be important, but also just incredibly difficult? That's what we are dealing with today.
I get that.
We're looking at chapter 62. The topic is lung cancer.
It is a heavy topic. There's really no way around that. I mean, it's the leading cause of cancer death worldwide, so the gravity is kind of built right into the statistics.
It really is.
But what I love about this particular source material, this chapter, is that it sort of strips away the fear and replaces it with biology. It treats lung cancer not as a curse, but as a biological puzzle.
And that is exactly our mission today.
Yeah.
We're going to deconstruct that puzzle. I think for a lot of people, and I'll include myself in this before I read this chapter, lung cancer just feels like a monolith.
Right. One big thing.
Exactly. You get a diagnosis and it's just this one big scary thing. But the reality is so much more nuanced. This isn't one disease. It's a collection of distinct cellular betrayals that just happen to occur in the chest.
That is the perfect way to frame it. I mean, if you walk away with nothing else from this deep dive today, it should be that understanding. Lung cancer is an umbrella term.
Just a category.
Just a category.
Wow.
And underneath that umbrella, you have all these different antagonists with different behaviors, different origins, and, most importantly, different vulnerabilities.
The source material draws a line in the sand right on page 1. It divides the entire world of lung cancer into two primary camps. On one side, you have non-small cell lung cancer, or NSCLC.
Yep.
And on the other side, you've got small cell lung cancer, SCLC. Now, to a layperson, that just sounds like a distinction of size. Is it really that simple? Is one just big and one is small?
That's a great question. And no, it's not really about the size of the tumor mass itself. It's more about the appearance of the individual cells under the microscope.
Oh, okay.
But the reason this distinction is the big one, the reason it's the absolute first thing any oncologist needs to know, is because these two categories, they act like completely different species. They have different natural histories.
Natural history is a phrase that comes up a lot in the text. It essentially means, what does this disease do if we just leave it alone, right? That's the idea.
Exactly. It's the personality of the cancer. And small cell lung cancer, SCLC, that's the aggressive one, I often compare it to a swarm. It divides incredibly fast, it moves quickly, and it spreads, metastasizes to distant parts of the body very early in the game. It is high velocity.
A swarm. I like that. So versus non-small cell.
Well, non-small cell is the majority. It represents about, 85% of all cases.
Right.
And it tends to grow a bit more slowly. It's more methodical. That doesn't mean it isn't dangerous, not at all. But it gives us a different set of strategic options. You don't fight a swarm of bees the same way you fight a tank.
Right.
You need different weapons.
We are definitely going to get into those weapons, the surgery, the chemo, the what you called the molecular snipers later in the deep dive. But I want to rewind. I want to go back to the very beginning. The origin story.
The cellular betrayal.
Yeah. How does a normal, healthy bronchial cell, whose only job is to line your airway and help you breathe, how does it decide to go rogue?
It's a fascinating, albeit, tragic biological process.
Yeah.
The source describes it as the accumulation of multiple genetic lesions. It's not one single event. It's a story of cellular betrayal that plays out over years or even decades.
And the text breaks this down into a few specific mechanisms. He talks about proto-oncogenes and tumor suppressor genes. I've always found the car analogy works best here for me to wrap my head around it.
It's the classic analogy for a reason. It works perfectly. So think of a cell like a car. A proto-oncogene is the gas pedal.
Okay.
In a normal cell, you press the gas when you need to grow or repair tissue, and then you let off. It's controlled. But if that gene gets mutated, if it becomes an oncogene, the pedal gets stuck to the floor.
Permanently on?
Permanently on. The engine just revs, and the cell starts dividing uncontrollably.
But a car also has brakes. It has to.
Exactly. And those are the tumor suppressor genes. Their job is to spot trouble. If a cell's dividing too fast or has damaged DNA, the tumor suppressor gene, it pumps the brakes. It can even tell the cell to commit suicide, a process called apoptosis, to save the organism.
That's incredible.
It is.
So in lung cancer, you have a situation where the gas pedal is floored and someone has just cut the brake lines.
Precisely. You really need both insults to get a malignancy going. And then the source mentions a third factor that really seals the deal: autocrine growth factors.
This part gave me chills when I read it. It's essentially the tumor going off grid.
It is. It's terrifyingly clever. Autocrine means self-secreting. So normal cells, they wait for signals from the body to tell them what to do.
Right, they listen for instructions.
Exactly. Cancer cells, though, they start manufacturing their own growth hormones. They produce the fuel and they consume the fuel. They become these completely self-sufficient biological machines.
Wow. So they just disconnect from the body's entire regulatory network and start building their own empire inside you.
There's a perfect description.
Now, we have to talk about what causes these genetic lesions. The mutations that stick the pedal and cut the brakes. The source is, it's very blunt about the primary culprit.
It is unavoidable, and it has to be said. Cigarette smoking is responsible for approximately 80% of lung cancer cases.
80%?
Smoke contains a cocktail of carcinogens, polycyclic aromatic hydrocarbons, nitrosamines, that are they're chemically designed to damage DNA. They physically bind to the DNA helix and cause those copying errors we just talked about.
That is a massive number. It completely dominates the conversation, but I want to spend some time on the other 20%.
Good, it's important.
Because I think there is a misconception out there that if you don't smoke, you're immune. And the source makes it really clear that is not true.
It's absolutely not true. There are significant risk factors for non-smokers. The text highlights environmental respiratory carcinogens. Asbestos is the most famous one, historically associated with construction and insulation.
Right.
It increases the risk of lung cancer and also a very specific cancer of the lung lining called mesothelioma.
But it lists others that kind of surprised me. Benzene, arsenic.
Yes. These are often occupational hazards. Arsenic can be found in smelting operations, glass making, and even some pesticides. Benzene is heavily associated with the petrochemical industry. And we shouldn't forget radon.
Radon and rope.
The text mentions it as a silent risk, a radioactive gas that can seep into homes from the ground, totally invisible and odorless.
And there's a point about history in here, too. If you have a history of other lung diseases like COPD or asthma, your risk goes up. Why is that? Is it just that the lungs are already weak?
It's more about inflammation. Chronic inflammation is like a smoldering fire.
Yeah.
When you have COPD or asthma, your lung cells are constantly being damaged and having to repair themselves.
Okay, I see.
That high rate of cell turnover, that constant repair work, it just increases the statistical probability that a mistake will happen in the DNA replication. It creates a fertile soil for the cancer to take root.
So you have the soil, the inflamed lung, and then you have the seed, the mutation.
That's the model.
Now let's look at the cast of characters again. We said 85% of cases are non-small cell lung cancer, NSCLC. But even that isn't a single group. The source breaks it down into a family tree.
Right. So if you zoom in on that 85%, you usually find three main subtypes. The most common by far is adenocarcinoma. That accounts for about 50% of all lung cancers.
Half of all cases. And strictly from a geography standpoint in the lung, where does adenocarcinoma usually live?
It tends to arise in the periphery of the lung, the outer edges.
The edges. Okay.
And this is clinically really important because since it's on the edge, it might not cause a cough or block an airway until it gets quite large. It can grow silently for a long time.
Okay, that makes sense. Then you have squamous cell carcinoma.
That's the next most common, just under 30%. Squamous cells are the cells that line the major airway, so these tumors tend to be central. They grow right in the middle of the chest, near the big bronchi.
And because of that location.
Because of that location, they often announce themselves earlier with a persistent cough or by physically blocking airflow. They're noisier, clinically speaking.
And the third sibling in this family?
Large cell carcinoma. This is sort of the diagnosis of exclusion. It consists of these large, undifferentiated cells that don't really fit the specific criteria for adeno or squamous. It's the aggressive cousin in the non-small cell family.
Okay, so here's a question that I think is crucial for the listener. Why does this breakdown matter? Is this just for pathologists to argue about at conferences, or does it actually change what happens to the patient in the clinic?
That's the million-dollar question. And, 10 or 15 years ago, the answer might have been, it doesn't matter all that much. Yeah, we pretty much treated them all the same. Today, it matters immensely. The histology, whether it is adeno or squamous, it dictates the exact chemotherapy we use. There are drugs that work wonders on adeno that are actually dangerous for squamous.
Wow.
And beyond that, the cell type tells us which specific genetic mutations to hunt for.
So it's the first step on a very specific decision tree for treatment.
The absolute first step. It's foundational.
We're definitely going to get into those specific drugs and mutations in a bit. But first, let's move on to section 2, the detectives. How does this disease actually present in the real world? We mentioned the cough.
The cough is the most common symptom, yes. But the source paints a picture of a whole constellation of symptoms. You have dyspnea, which is shortness of breath. You have chest pain. And you have hemoptysis.
Which is coughing up blood.
Coughing up blood.
That's the scary one. That's usually the ticket to the ER, I imagine.
It is. It often happens when the tumor erodes into a blood vessel in the airway. But the source also emphasizes systemic symptoms, things that happen to the whole body, not just the lungs.
Like what?
Anorexia, significant weight loss, just profound fatigue.
It's a wasting syndrome.
Exactly. The tumor is a parasite. It's a metabolic parasite. It is consuming the body's energy reserves to fuel its own rapid growth, and it's releasing these inflammatory chemicals that tell the brain, we're sick, don't eat.
That's awful. What about when it spreads? The text uses the phrase disseminated disease. Where does lung cancer go when it decides to travel?
It has a few favorite destinations. It loves the central nervous system, the CNS. Metastases to the brain can cause headaches, confusion, seizures, or even stroke-like symptoms.
Okay.
It also loves the bone, spine, ribs, hips. This causes a severe gnawing bone pain and can lead to what are called pathologic fractures.
Pathologic fractures, that's when the bone breaks just from normal movement, right? Not from a major injury.
Yes. The cancer literally eats away the structural integrity of the bone until it just snaps under the weight of, say, standing up or rolling over in bed.
That's horrifying.
And finally, it very commonly travels to the liver and the adrenal glands.
Now, I want to pause on something here that I found completely fascinating. The source calls them paraneoplastic syndromes. To me, this felt like the plot of a medical mystery show. We're talking about the cancer causing symptoms in parts of the body it hasn't even physically touched.
This is one of the strangest and most complex aspects of lung cancer biology. It's really mind-bending. Basically, the tumor cells, they revert to this primitive, almost embryonic state and start producing hormones that they have absolutely no business producing.
So they're hacking the body's communication system.
They're hacking the body's entire endocrine system. It's remarkable.
Let's look at the examples the text gives. The first one is hypercalcemia.
Right. So usually squamous cell carcinoma is the culprit here. The tumor starts secreting a protein that is almost identical to parathyroid hormone. This fake hormone travels through the blood to the bones and tells them to just dump all their calcium stores into the bloodstream.
So the lung tumor is remotely dissolving the patient's skeleton.
In a way, yes. And the patient doesn't come in complaining of a cough. They come in with high calcium, which causes confusion, kidney stones, abdominal pain. But the root problem is in the chest.
Unbelievable. And what about SIDH?
Syndrome of inappropriate antidiuretic hormone. This is a classic one for small cell lung cancer. The tumor pumps out ADH, which is the hormone that tells your kidneys to hold on to water.
Okay.
The patient retains so much water that their blood sodium levels just plummet. It can cause seizures and even comas, all from a tumor in the lung.
And finally, Cushing's syndrome.
Again, usually small cell. The tumor makes a hormone called ACTH, which drives the adrenal glands to pump out massive amounts of cortisol, the stress hormone.
And what does that look like?
The patient gains central weight, develops a moon face, gets high blood pressure, their skin gets thinner because of a tiny nodule in the lung acting like a rogue pituitary gland.
It's incredibly deceptive. It's like the cancer is a ventriloquist.
That is a fantastic analogy.
So you have a patient with some of these symptoms. How do the doctors confirm the diagnosis? What's the technology stack?
Well, you usually start with the basics, a chest x-ray. But that's a pretty blunt instrument. The real heavy lifting is done by the CT scan and the PT scan. And the source makes a very specific point here. Integrated CT-PT is superior to either one alone.
Why is that? What does the PT scan add to the picture?
Okay, so a CT scan is pure anatomy. It's a map of the roads and the buildings. It shows you there's a lump here.
A structural map.
Exactly. But it can't always tell you if that lump is active cancer or if it's just old scar tissue. A PT scan, on the other hand, is metabolic. You inject a form of radioactive sugar into the patient.
And cancer loves sugar.
Cancer cells are hungry. They're metabolic furnaces. They eat sugar much, much faster than normal cells. So on the PT scan, the active cancer lights up like a flare.
So the CT tells you where it is, and the PT tells you what it's doing.
Exactly. And that combination is crucial for finding those distant metastases we talked about. If a spot lights up in the liver or a bone, you know it's likely cancer that is spread.
But even with the most advanced scans, you can't treat a picture. You need tissue.
Pathologic confirmation is mandatory. That's the quote from the book. You have to get a sample. You have to have cells under a microscope.
And how you do that?
It's usually done via bronchoscopy, going down the throat with a camera and taking a little bite or a needle biopsy where a radiologist guides a needle through the chest wall directly into the tumor. We need to see those cells to know if we're dealing with small cell or non-small cell and to run all those critical genetic tests.
Which brings us to mapping the battlefield. Staging.
Staging is simply how we quantify the enemy's advance. For non-small cell lung cancer, we use the internationally recognized TNM system.
TNM?
T for the size and extent of the primary tumor, N for the involvement of nearby lymph nodes, and M for metastasis, or spread to distant sites.
I want to drill down on the N, the nodes. Why is lymph node involvement such a huge turning point in the staging process?
Because the lymphatic system is the highway to the rest of the body. Think of it this way. If the cancer is just in the lung tissue, that's a stage IIF. It's walking.
No.
If it gets into the lymph nodes, that's stage 2 or 3, it has entered the on-ramp to the highway. It suggests that cancer has learned how to travel and is trying to leave the chest.
The text distinguishes between ipsilateral and contralateral nodes. Can you translate that for us?
Sure. Ipsilateral means same side. So if the tumor's in the right lung and the lymph nodes on the right side of the chest are involved, that's usually a stage 2. It's serious, but often still potentially curable with surgery or radiation.
But contralateral?
Contralateral means the cancer has crossed the midline. If the tumor is on the right, but the lymph nodes on the left side are now involved, that bumps you up to a stage 3. It means the cancer has crossed the river, so to speak. It's a much more advanced situation and much harder to treat with just local therapies like surgery.
And stage 4 is just distant metastasis, game over for a surgical cure.
Yes. Once it's in the bone, brain, liver, or adrenal glands, it's stage 4. The cat is out of the bag.
Now, for small cell lung cancer, the swarm, the text says we don't usually use the complicated TNM system. We use a simpler binary system, limited versus extensive. Why the simplification? Is it just not as useful?
It's because SCLC moves so fast and is considered systemic so early that the nuanced distinctions of TNM often don't change the management. The question for SCLC is purely logistical. Can we treat this with one field of radiation?
So how is limited disease defined then?
It's defined as disease confined to one hemothorax, or one side of the chest, that can be encompassed by a single radiation port. Basically, can we draw a box on the CT scan and fit all the known tumor inside that one radiation field?
And if it's spread too far for that, if there are spots in both lungs or it's gone to the liver?
It is extensive disease. And unfortunately, because of the incredibly aggressive nature of small cell, about 2/3 of patients present with extensive disease right at the time of diagnosis.
Okay, so we've identified the enemy, we've found it, and we've mapped its location. Now comes the fight. Section 4, the strategy for non-small cell lung cancer.
This is where the complexity really explodes. The first decision isn't, which drug do we use? The first decision is, what is our goal?
What do you mean?
Are we going for a cure, or are we going for palliation, which means prolonging survival and managing symptoms, but with the understanding that a cure is not likely?
And the source mentions performance status as a major factor here. It sounds a little cold, but it seems incredibly practical.
It is absolutely vital. Performance status basically asks, how fit is the patient? Can they get out of bed? Can they do their own daily activities? Can they walk around the block?
And why does that matter so much?
Because chemotherapy and surgery are traumatic to the body. They are poisons and physical insults. If a patient is already bedridden and very frail, aggressive treatment might just destroy their remaining quality of life without adding any significant time. We have to treat the patient, not just the X-ray.
Okay, so let's assume the patient is fit. For early stage disease, stage 1 and TI, what's the weapon of choice?
Surgery, no question. If the cancer is contained, we cut it out. This usually means a lobectomy, removing the entire lobe of the lung where the tumor lives. It offers the best chance for a definitive cure.
But what if you can't cut it out? Maybe it's stage 3, or maybe the patient has bad lungs from years of smoking and they just wouldn't survive the surgery.
Then we turn to the doublet.
The platinum doublet. It sounds like a specialized cocktail from a very serious bar.
It is the standard of care for advanced or unresectable disease. And it's called a doublet because we almost always pair 2 chemotherapy drugs together. And the backbone of that pair is almost always a platinum-based drug, cisplatin or carboplatin.
Let's geek out on the mechanism for a second. Why platinum? What makes it so effective at killing cancer?
Cisplatin is a heavy metal compound. It gets inside the cancer cell and it binds directly to the DNA. It forms these rigid crosslinks. Think of it like putting handcuffs on the 2 strands of the DNA helix.
So it can't unzip itself.
It can't unzip itself to copy its genetic material. When the cell tries to divide, the process fails catastrophically. And since it can't replicate, It triggers apoptosis cell death.
That is brutal efficiency. And the second drug, the partner in the doublet.
The partner is chosen from a list of agents.
Mm-hmm.
Paclitaxel, docetaxel, gemcitabine, pemetrexed, or vinorelbine. These drugs all attack the cell division machinery, but in different ways. For example, paclitaxel freezes the microtubules, which is the internal scaffolding the cell uses to pull itself apart during division.
So you're hitting the cancer from two different angles at once.
Exactly. It makes it much harder for the cancer to develop resistance.
Now, the text notes something that really surprised me. It says, no specific combination is superior in efficacy. They all work about the same. So how do you choose which one to use?
You choose based on the toxicity profile and the histology. Each partner drug has different side effects. Paclitaxel can cause neuropathy nerve damage in the fingers and toes. Gemcitabine might hit the blood counts harder.
So you tailor it.
You tailor the toxicity to what the patient can handle. If a patient is a professional pianist, maybe you avoid paclitaxel to protect their fingers. If they already have some kidney issues, you switch from the harsher cisplatin to the gentler carboplatin.
Now, we need to loop back to that histology discussion. Adeno versus squamous. This is where the one-size-fits-all model completely breaks down, right?
This is a critical safety point.
Yeah.
This is non-negotiable. There's a drug called pemetrexed. It is incredibly effective for non-squamous cancers like adenocarcinoma. It works by targeting folate metabolism, which these cancers rely on.
Okay.
But for squamous cell carcinoma, it is effectively useless. The biology of squamous cells makes them inherently resistant, so you never ever give pemetrexed to a squamous patient. It's all toxicity with no benefit.
And there's another one, bevacizumab. This is a targeted therapy, a monoclonal antibody.
Right. Bevacizumab targets something called VEGF, vascular endothelial growth factor. Tumors need a blood supply to grow, so they send out these VEGF signals to the body saying, build me a highway, I need nutrients.
So bevacizumab blocks that signal.
It blocks the signal. It starves the tumor of its blood supply. It's an anti-angiogenic agent.
That sounds like a great idea. Why is there a warning label on this one?
Because of where squamous cell tumors live. You remember we said they're central, right next to the major blood vessels of the heart and lungs. If you use bevacizumab to melt away the tumor and stop blood vessel repair in that very sensitive area, you risk catastrophic fatal bleeding.
Hemoptysis.
Massive fatal hemoptysis. So bevacizumab is absolutely contraindicated in squamous cell cancer. It's only for non-squamous tumors that are located more peripherally. This is why that initial biopsy is just so important.
Let's move to the real sci-fi stuff now. Targeted therapy. This is where we stop carpet bombing the whole body with chemo and start using snipers.
This is the era of precision medicine. It's a total game changer. We're no longer just looking at the cell type. We're looking for the specific genetic mutations that are driving the cancer. And the most famous one in lung cancer is EGFR.
Epidermal growth factor receptor. So, in simple terms, this is like a switch that's gotten stuck in the on-in position.
That's a perfect way to put it. In about 15 to 20% of adenocarcinomas, especially in non-smokers, the EGFR receptor is mutated, so it constantly tells the cell grow, 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 regardless of whether the body needs it to or not.
And we have a pill for that specific broken switch.
We do. A drug called erlotinib. It's a tyrosine kinase inhibitor. It's a small molecule that's been designed to fit perfectly into that mutated receptor. It acts like a key that you stick in the lock and break off. It jams the lock and turns the switch off.
And the results?
They can be dramatic. I mean, truly dramatic. Patients who might have had only months to live can see their tumor shrink rapidly, sometimes within weeks. They can live for years, often with much milder side effects than chemotherapy because the drug is specifically targeting the cancer's addiction, not just every dividing cell in the body.
And the same logic applies to the ALK rearrangement, another specific mutation.
Yes, exactly. For ALK-positive patients, we use a drug called crizotinib. It's the same concept. Find the specific broken gear in the machine and design a drug to jam that one gear.
Whoa, and I feel like there's always but with cancer is adaptable. It's clever.
It is evolution and fast forward. Eventually, the tumor often mutates again. It changes the shape of the receptor just enough so the drug doesn't fit anymore. That's how resistance develops. And that's when we have to pivot and look for second-line options.
Let's pivot now to the other enemy, small cell lung cancer, SCLC. The swarm. If non-small cell is a strategic chess match, small cell feels more like a frantic brawl.
It is urgent medicine. Small cell has a frighteningly short doubling time. We're talking weeks. If you diagnose it on a Monday, you really want that patient starting treatment by Wednesday or Thursday of the same week. You just don't have time to wait.
do we operate? We said surgery was the best shot at a cure for early non-small cell.
For small cell, surgery is very, very rarely an option.
Why is that? Even if you catch it when it's just a tiny spot on the scan.
Because by the very definition of the swarm, even if you catch it when it looks small and localized on a scan, we have to assume it has already micrometastasized. There are likely invisible cells already circulating in the blood or the lymph system.
So cutting out the main tumor won't stop the seeds that have already spread?
Exactly. It won't stop the systemic disease. Surgery is only ever considered for the extremely rare case of a tiny, solitary nodule with no other evidence of disease anywhere.
So if surgery is out, what is the main weapon against the swarm?
Chemotherapy.
Yeah.
Aggressive, systemic chemotherapy. We have to treat the whole body immediately. And the gold standard regimen here is EP, etoposide, plus cisplatin or carboplatin.
Why this specific combo? What makes it work so well against SCLC?
Small cell is incredibly sensitive to DNA damage, precisely because it's dividing so fast. It has less time to repair its mistakes. Etoposide works by physically breaking the DNA strands, and cisplatin, as we said, prevents those breaks from being fixed. It's a 1-2 punch that hits the cancer devastatingly hard.
The text also mentions that SCLC is very radiosensitive. What does that mean?
It means it melts under radiation. It's one of the most radiosensitive tumors we treat. That's the good news. The initial response rates to chemo and radiation are very high. 60 to 80% of patients will see significant tumor shrinkage at first.
But I'm sensing a but is coming.
The but is that it almost always comes back. It responds fast, but it tends to evolve resistance just as fast.
I want to talk about the brain again. There's a procedure mentioned in the chapter called prophylactic cranial irradiation, PCI. To a listener, this might sound completely extreme. We are radiating the brain, even if there is no tumor visible there.
And it sounds counterintuitive, I know. But here's the logic. The brain is what we call a sanctuary site. It's protected by the blood-brain barrier, which is this amazing biological filter that keeps toxins out of our delicate brain tissue. The problem is it also keeps most chemotherapy drugs out.
So the cisplatin is cleaning up the cancer in the lungs and the liver, but it can't get past the bouncer at the door of the brain.
Exactly. And since small cell lung cancer absolutely loves to spread to the brain, you have this dangerous situation where the rest of the body might be clear of cancer, but a few malignant cells are hiding out in the brain, completely safe from the chemo.
So they can just regrow from there.
They can. So in patients who have a good response to the initial chest treatment, we use PCI low-dose radiation to the whole brain to try and kill those microscopic hiders before they can grow.
We burn down the hideout before they can set up a new base of operations.
That's the strategy. And it has been shown to significantly reduce the risk of brain metastases and improve overall survival. It's a standard of care.
That brings us to recurrence. What happens when small cell comes back, which you said it almost always does? The source mentions a 3-month rule.
This is a critical prognostic marker. If the cancer comes back after 3 months of finishing the initial treatment, we call it sensitive. It implies the cancer hasn't fully figured out how to beat the drugs yet, and it might respond again. We might try the same drugs or switch to a second-line agent like topotecan.
And if it comes back within 3 months,
That is refractory disease. It means the cancer is truly resistant. It either grew right through the treatment or it bounced back almost immediately. The prognosis there is, unfortunately, very poor. Topotecan is the only FDA-approved second-line drug, but honestly, the response rates are modest at best.
let's move to section 6, measuring success. How do we know if we're actually winning any of these battles?
We rely on the scans. For non-small cell, we typically do a CT scan after 2 or 3 cycles of chemotherapy. We're looking for either stability, it hasn't grown, or shrinkage.
If it's working, do you just keep going with chemo forever?
No, usually you complete a defined course. 4 to 6 cycles is typical. The cumulative toxicity is too high to go on forever. However, for non-small cell, particularly non-squamous types, we're moving toward a concept called maintenance therapy.
This is interesting. What's that?
If the patient has a good response to their initial 4 to 6 cycles, we might then keep them on a single, gentler drug like pemetrexed or a targeted therapy pill indefinitely. It's like keeping the boot on the neck of the cancer to prevent it from standing back up.
A long-term suppression strategy.
Exactly.
And for small cell, how do you monitor that?
Similar monitoring. We check with a scan after 2 cycles, but with small cell, if there is no response, if the tumor has grown, you stop immediately. There is absolutely no point in poisoning a patient with toxic drugs if their tumor is growing right through them. You have to change plans.
We have to talk about that toxicity. We've listed a lot of heavy-duty drugs today. Cisplatin, etoposide, paclitaxel, these are not aspirin.
No, they are cellular poisons. And managing the collateral damage is a massive part of the oncologist's job. Cisplatin is notorious for nephrotoxicity, kidney damage, and ototoxicity, which is permanent hearing loss or ringing in the ears.
And paclitaxel causes that neuropathy you mentioned.
Yes, numbness and tingling and pain in the hands and feet that can be permanent. Plus, almost all these drugs cause bone marrow suppression. They kill the rapidly dividing cells in the bone marrow that make our white blood cells, red blood cells, and platelets.
Which leaves the patient vulnerable to everything else.
To life-threatening infections, profound anemia and fatigue, and bleeding.
And when you consider that the average lung cancer patient is often older, perhaps with a history of smoking, which means they might also have heart disease or COPD.
You are walking a tightrope every single day. You have to be aggressive enough to kill the cancer, but careful enough not to kill the patient with the treatment. It requires intensive monitoring blood work before every single dose, constant symptom management. It's a huge undertaking.
Well, we have covered a tremendous amount of ground. We've gone from the very first genetic lesion in a single cell to the complex strategies of the platinum doublet and prophylactic cranial irradiation.
We have. And I think we've seen that lung cancer is not a single diagnosis. It's a complex biological landscape where the histology and the genetics, they determine the map for everything that follows.
As we wrap up, what's the big picture takeaway for you? What does Chapter 62 tell us about the future of treating this disease?
I think it tells us that we are fully entering an era of nuance. It used to be a very nihilistic diagnosis. It's lung cancer. There's nothing we can do.
Right.
But now, with targeted therapies like erlotinib and with strategies like maintenance therapy, we're seeing a fundamental shift in our thinking.
A shift in how we define success.
Yes. For many patients with advanced disease, we are moving from a binary cure or die model to a chronic disease model. We are starting to manage cancer, much like we manage diabetes or high blood pressure.
Wow, that's a huge reframing.
It is. We might not be able to eliminate every single cancer cell from the body, but if you can keep the tumor suppressed, keep it from spreading, and maintain the patient's quality of life for months or even years, that is a massive victory.
Manage and live. That is a powerful concept. It changes the entire narrative from a losing battle to a manageable condition.
And in that extra time we buy for the patient, science advances even further. New targets are found, new drugs are developed. Time is the most valuable commodity we have in this field.
I think that's the perfect place to leave it.
Yeah.
We often talk about the war on cancer as if it's some kind of alien invasion. But as we've learned today, it's our own cells using our own biology against us. And that makes the precision of these new treatments, distinguishing the mutineers from the loyal crew, all the more miraculous.
Absolutely. It's the challenge and the beauty of it.
Thank you for diving deep with us today. It was a tough topic, but hopefully you now see the intricate machinery behind the diagnosis. We'll see you on the next deep dive.
Take care.